We're actually doing a series of trainings for the volunteer companions as part of our community development block grant. So this is the second. We did one before the holidays on helping people with mobility issues to get in and out of vehicles and kind of just being aware of safety for them. So this one is on dementia, Alzheimer's disease, and this is such a broad topic. I mean, I could teach a whole course on this, but we're not going to do that today. So what I'm going to do is just focus on a few of the basics of dementia in general, and then we're going to get into some of the specifics of mostly the behavioral, what to look for, signs and symptoms, as well as, just how to maybe de-escalate situations and things like that. So I think that's probably what you're more interested in. Hi there.
Yeah.
All right. You don't have to take any notes. I'm giving you these two handouts, and then the rest of what I'm going to cover today is all in a very nice packet. It's color-coded. It's bulleted. So you'll all be getting that, so don't worry about that. Welcome. How are you?
Good to see you, Gina.
Well, good to see you, too. We already did introductions. This is Dr. Frank Horrigan, who's retired now, but yeah. And you are, what's your name, sir? Ron. Okay, well, welcome to the training.
Let's take that. Nice.
Okay, so we're going to start with just an overview of dementia in general, because I think it's a term that a lot of times is used. It may be used a little inappropriately. So as you can see on your handout, dementia, it's the loss of cognitive functioning, thinking, remembering, reasoning, to such an extent that it interferes with the person's just their daily activities, all right? So some people with dementia can't control their emotions, and their personalities may change. Sometimes we see that. And dementia ranges in severity. It can be very mild, that you hardly even notice, to quite severe in the most severe stage. And in that case, the person is really dependent on other people. But I think what's most important is to understand that dementia in and of itself is not a diagnosis. It's a clinical syndrome. So it's kind of the umbrella. And then underneath dementia are actually the causes of it. It may be Alzheimer's disease. That's a big one. More than 50% of the cases of dementia are Alzheimer's. But it might be from something else. There's a dementia that's related to Parkinson's disease. Not everybody with Parkinson's has a problem with dementia, but some people do. HIV and AIDS, there's a dementia there. If the person has had a lot of traumatic brain injury, concussions through athletics or whatever, we see that sometimes with people in sports later on in their lives. So the term dementia, it kind of doesn't give you a lot to go on because it's so broad. But when we start getting into the types and, Lewy body dementia, there are all kinds. So I've listed a few. Vascular dementia. Vascular dementia is caused by a series of strokes or small strokes, TIAs, transient ischemic attacks. And vascular dementia tends to be kind of the person has a stroke or a small stroke. They might have some cognitive issues, and then maybe they have another one. If they start having series, it kind of is this step that looks like this. So they may stabilize for quite a while, and then they have another event, and then, possibly more cognitive decline. So that's listed on your overview of dementia. Okay, that's the white sheet that's there. The next sheet that I gave you was the green sheet, and I really gave you this. I found it to be very helpful when I was teaching, but I also found it very helpful because my dad had Alzheimer's disease, and it was helpful to my family. It's called the FAST. It's the Functional Assessment Staging in Alzheimer's disease. So this is very specific to Alzheimer's, which is primarily what I'm going to focus on today. And this was actually written up in one of the medical journals on the validity of this. What this does is it breaks down what happens when someone starts to go through what I call the journey of Alzheimer's disease. So they kind of descend into that cognitive decline. For some people, it happens very rapidly. For some people, it happens over years, and it's much less noticeable. Typically, if someone is diagnosed early on, the earlier the onset, the more rapid the decline. So if you have someone with early onset Alzheimer's, and when I say early onset, that could be 40s or 50s, it tends to be a more rapid decline. I think what we tend to see with our clients here is that the diagnosis comes later. It tends to be more gradual. This kind of gives you an idea of, again, this is typical. This is not, every case is not a textbook case, but the kinds of things that happen as people move through it. So if they're fine, number one, you can see where you start with number one, there are no difficulties. Number two, complaints of forgetting the location of objects. Sometimes some word finding difficulties. Now, that could be any of us. So sometimes it's all of us. Where did I leave my glasses? Where's my phone? Where are my keys? I mean, I can't, that happens to a lot of people. So again, there's no cause for alarm if you see that in your clients. Okay, not a big deal. But if you start to see some of these other things as we go, decreased job functioning, which might be evident to coworkers if the person is still working, difficulty traveling to new locations. Now, if they're going to, familiar places, I go to the grocery store, I go to the bank, I go to the hairdresser. But if it's someplace new, maybe a doctor's appointment that's in Springfield or even in Westfield, but a different location, that may present some difficulties. Decreased organizational capacity. So those are things that begin to start happening. And then we see a problem with complex tasks. For instance, so I gave you some examples, planning for dinner guests, because that takes some organization, right? Okay, what time are they coming? And I have to make the meal. What are we making? What goes in the oven first? What's going to go last? What can I make the night before? Those are all things that start to take, some brain power there that really requires some organization. Handling personal finances can become problematic, and that goes both ways. It could be that the person is forgetting to pay bills, but it could also mean that the person, because at this stage they're aware that something's going on, so they may start double or even triple paying bills. Well, did I really pay the water bill this month? Okay, I'll just pay it. So sometimes we've seen that too, where people have double or triple paid because they can't remember. And you can see, I'm not going to go through all of them, but you can see as you go along, and if you flip it over to the very end, when you get to like number 7 and you have A, B, C, D, E, and that's when the person is really in the end stage of the disease. So I find this tool to be really useful to families, not to scare them, but just to give them a heads up on this may be what you're up against down the road. Some people never get there. I mean, a lot of people who have Alzheimer's have other issues. They have heart conditions. They have, other issues. And in the end, it may be that, they don't die from Alzheimer's disease. They have a heart attack or something else happens. So it's not likely that everybody with the disease, and I can tell you, after working in this field for many, many, many years, I actually have very few people that went through all of this and got all the way to the end and then passed. Generally, but it did help families to plan so that, especially when you get into activities of daily living with people having an issue with being able to dress themselves or bathe themselves or, even choose clothing. So it just kind of helped families in that planning stage. Sometimes it's just a matter of having families be able to figure out when it's time to bring in some extra help. I can manage this as my spouse or my, the daughter or son or whoever with caring for this person. But once we get to, maybe it's the incontinence issue. That gets to where it kind of starts out with difficulty finding the bathroom. Where's the toilet? Then difficulty sort of knowing, okay, I'm continent, I know when I have to use the toilet, but I forget that I have to flush it, or I forget how to flush it. There are lots of things that can happen along the way. So again,
Sure. Early on, it's a good idea, while they're still pretty well functional, to go over with them how they see health problems and end-of-life planning and develop what we call a healthcare proxy. That is somebody who makes a medical decision. If the doctor says the patient is not able to, proxy makes the decision based upon what the patient had told them they would like to have happen.
Mm-hmm.
Okay, then the proxy is not making the decision. Proxy is announcing what the patient had said. along a parallel track, it would be a good idea if the patient had a durable power of attorney that could help with financial issues and have a legal basis for some time.
Right. Which is very important. Whole other topic that we could spend an hour on, the legalities, because that is absolutely important to have that healthcare proxy in place, to avoid guardianship and conservatorship, and also to let both your loved one as well as your medical team know what your wishes are. But again, that truly is a whole other training that we can get into. And I know Mike's going to be doing a legal training. That's one of the ones that's coming up. So that will be the next in-person one. All right, so those are sort of the overview of dementia. Just the FAST is just kind of a tool that can be used. And now I really want to get into the nitty-gritty of what we're going to talk about today. And again, you're going to get handouts on this, but I'm not going to give them to you until you're ready to leave, just so that you pay attention. All right, so let's talk a little bit about, we mentioned the forgetfulness piece, and, everybody kind of said, well, I do that. I do that. I lose my phone. I lose my keys. So let's talk about normal forgetting versus forgetting if you've got somebody with a more serious problem. All right, so first of all, let's start with number one. If a name is forgotten, it's usually remembered later on. So that's called delayed recall. So, I went to my niece's wedding and I saw so-and-so and so-and-so. What the heck was her husband's name? It's Julie, and what was his name? Bob, Joe, Mike. Can't remember that. Okay, an hour later, I remember. It was Steve. I knew it was the name of one of my brothers. I couldn't figure out which one. So that's called delayed recall. You remember it. The person with Alzheimer's is going to forget the person altogether. So they're going to forget that, the niece was married to somebody. Well, what was her husband saying? Was she married? No, I don't think there was anybody there with her. So that's one difference, right? Normal forgetting usually includes forgetting parts of things, but those with AD forget entire experiences. So if I say, well, last night we went out for dinner, and we had a wonderful time, and we took a walk afterward, and we were down by the lake, and all this. The person with Alzheimer's not only isn't going to remember that you took a walk after dinner, they're going to forget that you went out for dinner last night. So again, it's normal forgetting. What we do is if I'm recounting my work day, it might be, oh yeah, I totally forgot. Or in this case, I forgot Lynn, okay? One person, okay? But I immediately, it's like, oh my God, we got sidetracked after Evelyn, and then we went on to other things. But somebody with Alzheimer's wouldn't necessarily remember that they forgot Lynn and might forget, totally who she is anyway, So that's another difference. Normal forgetting usually involves things that happened a long time ago. We can usually remember things that happened this morning and yesterday and so forth. And with Alzheimer's, it's usually flipped. So short-term memory is much worse than long-term memory. So somebody with Alzheimer's, if you say, what did you have for breakfast? I didn't eat breakfast today. When you may be the caregiver and say, yeah, you did. You had, 2 pancakes and some salt, whatever, right? They might remember, though, if I say to them, tell me about when you went to school. Oh, I had the most wonderful teacher when I went to school, and they can go back and tell you all about that. So long-term memory tends to be better than short-term memory. Short-term memory, what they did yesterday, what they did an hour ago, sometimes it is just gone. And people can't understand that because it's like, and I've had families say to me, well, she can remember, that her wedding or her anniversary or, yeah, because that's kind of the nature of the way forgetfulness works with this. Normally, forgetful individuals never lose the capacity to be self-orienting, and I'll explain that in a minute. They know how to check for clues. But those with Alzheimer's disease lose the capacity to search for and use clues that would help orient them. So I'll give you an example of that. So I'm in my office, I'm working on the newsletter. It's like, all right, I'm on page 7. That's Lynn's page. I need to go ask Lynn if she has anything new and different. Is there something I'm supposed to be putting in there? I have a deadline. I go downstairs, and when I hit that bottom step, Sandra from the greeter's desk said, "Oh, Tina, somebody came in, blah, blah, blah." And, they wanted to talk about taxes. So now I'm talking about that. And then Evelyn comes and says, somebody wanted this piece of medical equipment and yada yada. And so I talked to her. Now I'm standing there going, what did I come downstairs for, right? How often have we done that? And and there are times when I absolutely cannot remember. But obviously I came down for something, and it wasn't to talk to Evelyn or to Sandra. So what do? If I can't remember, I go back up to my office. I have to go back to where I started. Yeah. That's called reorienting. So I go back to my office. I take one look at my computer. It's got my newsletter on it. I'm on page 7. That's what I went downstairs for. I went downstairs to talk to Lynn about if she needed me to put anything in the newsletter on her behalf. So we have that ability. Somebody with Alzheimer's, if you put them in that situation, they would hit that bottom step. They'd talk to Evelyn. They'd talk to Sandra. They'd walk around, and everything else is forgotten. They don't remember that I came down here for a specific reason. So they're just going to wander around. And by the way, that is one of the reasons that people with Alzheimer's and dementia wander. Sometimes they're looking for a clue, but they don't know what the clue is that they're looking for. So, we hear a lot about wandering outside, inside. And sometimes it's just because they're just trying to find something familiar that they can hang on to and grab onto. And if they don't find that, they just keep wandering to sort of look for something. Another topic, but anyway. All right, so that's basically some of the differences on forgetfulness. So if you, as a companion program volunteer, notice that someone is forgetful, sort of try to figure out how important is the forgetfulness and sort of what the nature of that forgetfulness is, because that will help to give you some clues. Okay, let's talk about possible inappropriate behaviors exhibited by some people with Alzheimer's. This laundry list doesn't apply to everybody with Alzheimer's. And, no two cases, they're people. I mean, we're all different. So anybody dealing with not just Alzheimer's, anything, arthritis, a heart condition, a bum hip, we're all going to, respond a little differently. But these are some things that we see a lot of. It could be fabricating stories about how things happened. Now, in my experience, that's generally earlier on in the dementia, because at that stage, the person knows there's something wrong, but they don't know what, and they don't want to look stupid. They don't want to look ignorant. And so if you kind of call them on something, well, Dad, you were supposed to call me if you needed transportation to the doctor's appointment, and you didn't call me, so I assumed you were okay. And now, the reason that Dad didn't call was because Dad forgot, but he doesn't want to tell you that. So it might be, well, yes, I did have something lined up, but then that fell through. So, you get these stories. Now, later on in the diagnosis, and I always say there's kind of this line somewhere along the way where on this side of the line, the person is aware that there's something wrong. They don't necessarily know what, but they know there's something wrong. So that's when you'll get the fabrication of stories. If they cross that line where they just don't have a memory that there's something wrong, that's when you tend not to hear the fabrication. And of course, by that time too, they're having a lot of difficulty with word finding, so it's harder for them to even come up with, some kind of a story. Another behavior that we often see is not remembering family members. Now, that usually happens in a progressive order. The first person that they're going to forget is not going to be their spouse. That's going to be the last person. But if they're going to forget people, it's going to be, somebody I see at funerals, somebody I see at a wedding, once every 5 years, once every 10 years, once every 2 years. This nephew or that niece, especially if they live out of state. So it happens that way. But if the person, it has the diagnosis for a long enough period of time and it progresses, they're going to get to where they might not recognize the grandchildren or know the grandchildren's names. And then it might be the children. And ultimately, it might be the spouse. Because if you think about where we were, what I talked about before in terms of long and short-term memory, what they can remember goes back farther and farther. So at some point, they may get to the point where they don't recognize a spouse because I don't know that I'm married. I'm back farther than that. And that's really unsettling to family members, as you can imagine. And certainly for you as volunteers, they're not necessarily going to remember you unless you're on sort of a weekly schedule with someone. But even at that, I mean, my father had Alzheimer's and kind of was a little textbook with some of this. And I think got to the point where he didn't recognize me. I lived out of state, but I was there like every 6 weeks flying down to Tennessee. But he did recognize that I was someone familiar. And so he was okay with that. Didn't know my name, so it was always like a nickname. But he was comfortable with me. And I think at that point, pretty much the only names he could remember were my mom's, which he remembered right till the end, and my brother who lived down there, and was there. He saw him on a regular basis. So that tends to be progressive. Another behavior is losing things. And again, it goes beyond sort of, I can't find my keys. I mean, sometimes it's like something that the person just had 5 minutes ago, and it's kind of like, okay, where'd you put it? And then, you're on this hunt to try to find things. We talked a little bit about either not paying or double paying bills. That tends to be in the earlier stages when people are still managing their own money. Unable to follow directions. And so usually what happens, especially directions that have multiple parts. So if I say, I used to say to my dad, oh, Dad, can you go in your bedroom and get out, your black socks, because I'm going to, help you put those on, and then just bring them back. He might remember to go in the bedroom. He is not going to remember what he went in there for. So we have sort of the wandering thing. And he'll come back either with something like a hanger or something completely different, which he was known to do, or just come back as if, hi, how are you? Did you just get here? There's like no recollection. So here's the one that just is so problematic for families especially, and that is repeating questions or stories over and over and over again within minutes. And I was actually talking about this on, I do a cable show, and I was talking about it on the show this morning. I had a protective service director from Highland Valley, and we were talking about how challenging that can be for caregivers, whether it's a spouse, or whether it's a child. When you have someone, and they didn't wake up in the morning and say, how can I irritate the heck out of, they didn't do that. But, it just gets to the point where, like, for the 30th time, when is Evelyn coming to visit? When is the nurse coming? Okay, she's going to be here Thursday in the afternoon. Okay. 5 minutes later, is the nurse coming today? No, today's such a, and it's just, that's their memory. That's what they can hold on to. But it is very, very challenging for family, for volunteers, for everyone. Taking other people's possessions, thinking they're her own. For years, I worked in a nursing home, and I had a woman whose room was right near my office. And every morning, she would come in with something. A stack of, usually it was like a pile of clothing. So she would go in somebody's drawer. So the first time she did it, she came in and she had like all these sweaters, like 3 or 4 sweaters stacked. She put them on my desk. And I said, how nice. And I'm thinking they're hers. So I said, okay, well, this is, okay, thank you for showing me. Let's go put these back in your drawer. I'm opening her drawers going, her drawers are full. Okay, now the hunt. Were they her roommates? Were they from down the hall? She got really creative. She was on other wings, and then I'm going, whose wreath is this? I remember one time I had this man who came in, and he was nonverbal, and it was at the holidays, and somebody had brought in for someone this beautiful poinsettia plant. It was like this big. He was completely nonverbal, came into my office. It was like 7 o'clock at night, put this down on my desk. He was so proud of himself, and I thought, oh, dear Lord, now I got to figure out where this came from. And I'm wandering up and down the hall asking all the nurses, all right, who got the poinsettia? I think that was down in that room. Again, common because they can't remember. We talked about pacing or wandering. This can also be very unsettling for families because sometimes people will experience like anger outbursts. So they might become, sort of verbally abusive. They might become loud. They might even strike at someone if they're, again, this is not everyone. Interestingly, when my dad was diagnosed, my brother shared the same father. His mother-in-law, so his wife's mother, was also diagnosed. Both had Alzheimer's, both roughly in the same stages. Completely different. She was happy-go-lucky. If you said to her, well, Mama Ruth, but we told you that before, so that's the same. Oh, silly me. She was like that. My father his personality was very different. He was used to being in control. He had a high-powered job in the government. And so, for us to say, well, no, Dad, that's not what we're doing. Well, that would really send him. And that was, I've seen when I was growing up, I had seen my dad angry. But boy, I'll tell you, with Alzheimer's, there were a couple times he was downright scary. He never went out, he never struck any of us. But, pounding of the fist on the table and, just really, really getting himself all upset. So that can happen. We're going to talk about how to sort of de-escalate that. Another thing that can be really unsettling for families especially is if someone is asking to go home, but they're already home. And again, it's that, it's not, if it becomes unfamiliar, and again, this is going to be later on, this is going to be later in the stages, because usually home is, sort of their grounding place. But if they get to the point where they can't remember it, that can be really challenging for families. And then you get into some of the self-care, unable to dress themselves, not remembering how to eat correctly or how to use utensils. And again, if it gets into the later stages, it's, you're kind of back to like finger food types of things, sandwiches, cut up small, those kinds of things. Refusing to bathe, that can also be, pretty common among folks with cognitive issues. So the other thing that can happen too is, and this is just, I did not read this in any book, but having worked in a number of nursing homes over the years, and I don't know if you saw this, Dr. Horgan, it was folding things. It was like having this need to fold things. Like I would have people that would I would have women in the old days, they used to wear skirts and they would like fold their skirts. They would, do this. So we used to give people, like washcloths and towels when I was in the nursing home and, kind of just let them go to town. I don't know what that's about. Can't tell you. And then, of course, incontinence. And again, for some families, that becomes a real problem. That becomes where they feel like, I can't do this anymore. Not always, but sometimes. So some possible. Again, this is not, it's not textbook. You're not going to see somebody generally with every single one of these, but you'll start to see some patterns. So again, when you're with your clients, if you start seeing 3 or 4 of these, it might be that red flag of, okay, there's something more than just they're older and a little forgetful. So the other thing that I really want to spend some time focusing on is communication strategies, which I think will really be helpful for all of you. So if you don't remember anything else that I say today, remember this. Nonverbal communication with folks with dementia and Alzheimer's is really more important than what you say, because in some cases, they're not going to be able to process your words, but they can feel your emotions. So if you want to de-escalate a situation, and we'll talk more about this as I go through this, you really want to stay calm. And that can be hard to do for a whole variety of reasons, and we can talk about some examples. But let's start with just this piece on nonverbal communication. So the person with Alzheimer's disease can understand touching generally better than words. So what does that mean? So that means you want to move slowly. You don't want to startle them. You want to, if you are going to touch them, do it gently, maybe just a hand on an arm. You also have to be sensitive to the fact that some people just don't like to be touched at all. So that's a clue. But for some people, and I used to just use the hand on the hand or the hand on the arm generally works. Sometimes, just on the back or on the shoulder. But again, you got to be a little careful. I don't mean, hugging and all that. I'm just, just like a gentle and just sometimes not even saying anything, just get that to kind of, get the person to calm down a little bit. Stand or crouch face to face to maintain eye contact. So that's another thing that's really important. So you want to, if they're sitting, I can't move. Like Mike has me on this camera, so I can't move to demonstrate this. But normally, if I was standing, I would crouch so that I was on their eye level. And that's important too if you're working with somebody who's hard of hearing. It's much better if you're on eye level. And if they're standing, for you to stand. And, just smiling and nodding your head. I did a lot of this with my dad. Because it just helps the person to kind of begin to breathe a little bit, calm down a little bit. If you slow down, I'm from northern New Jersey, so I tend to talk really quickly. But I have to remind myself, when I was with my dad especially, I would, or any of the clients that I worked with, and I worked with a lot of people, hundreds that, had AD or some other dementia, to just slow down, because the calmer I was, the calmer they would become, even if they were upset and angry. So let's talk a little bit about helping that person to communicate, because one of the things that happens with Alzheimer's, one of the early stages, is that people have difficulty word finding. So, these may be, those things that you see, your eyes, they can't come up with glasses, okay? So as they progress into Alzheimer's, it becomes more difficult for them to communicate because their vocabulary is dwindling. So it's hard for them, even if they know what they're trying to say, it's hard for them to say it. So you want to be calm and supportive, maintain your eye contact, use touch just to show them that you're here. You're not, you're waiting for them. We'll figure it out together. We're going to figure out what you're trying to tell me together. You want to pay attention to the person's voice and the gestures for clues as to what they're saying or feeling, so that if they're doing this, but they can't get the word sweater or jacket, you might say to them, "Are you cold?" Because a lot of times they'll be able to answer that question with a nod even, so go to your yes/no questions. Are you cold? Would you like a sweater? Or are you hungry? If they're touching their stomach. So you have to kind of look for some clues. And if you can't understand, again, you just want to remain calm, but just say, "Can you point to it?" Can you point to what? And sometimes they'll be able to just do that. Maybe they'll point to a room. Okay, now we've at least narrowed it down. It's something in the bedroom, or it's something in the kitchen, or it's whatever it is. So again, the main thing is to really just try to remain calm. And that could be hard because it's very frustrating for people to know what they want and not be able to get that across to you. So they may be escalating. Your job is to just stay calm. All right, helping the person to understand. So if you're trying to explain something to them, how's the best way to do that? Well, first of all, you want to approach them from the front, because go back to what we said with nonverbal, you don't want to startle them. So coming up from behind to say, "Hey, Dad," that's not a good idea. So approach them from the front. Really, really important. Try to keep the distraction and the commotion that's going on outside to a minimum. So in other words, when I did home visits, the first thing I used to do was shut off TVs and radios. And I would just say to the person, "Is it okay if we turn off the TV just so that we can, focus here?" Or if you're in a room with a lot of people, if you could take the person into a corner or into another room, because all of that distraction is really challenging for people with Alzheimer's. Begin each conversation by identifying who you are, especially as a volunteer. Remind them of who you are. I'm Sally and I take you grocery shopping every week. Because again, you kind of look familiar. Now, what are you here for? What are we doing here again? So that's really helpful to, let them know who you are and let them know, why you're there. Again, we're back to speaking slowly, speaking clearly. Because the other thing that you have to remember is a lot of people with Alzheimer's or some kind of dementia also have other things. They may be hard of hearing. They may have visual deficits. In my dad's case, he had a visual deficit. So not only did we have the Alzheimer's, but he also had no vision in one eye and very limited vision in the other eye. So that was also problematic. Use a lower pitch to convey a sense of calm. And most of you are women, and myself included. What happens when we get excited and loud? Our voice tends to go up. Yeah, which is exactly what you don't want, because that evokes the whole sense of panic. You don't want to do that. So if you can, keep your voice lower and slower. Use short, simple, and familiar words and sentences, because again, remember that people are losing their vocabulary as the disease progresses. So just keep it short, keep it simple. That was difficult for my mom, because my mother had always, like me, has a tendency to want to explain everything. We're going to go to the bank today because, and then she would launch into this whole thing about, well, we need money for this, and I got a bill to pay over here, blah, blah. And it took me a long time to say, Mom, all you have to say is, Al, we're going to go to the bank today. Let's get dressed, or let's get our jackets. Because all the other stuff gets it's just way too confusing. And then they're trying to process, and then you're putting the burden on them to process, well, what's really important out of all this stuff that you've just told me? Well, the important thing is we're going someplace, get your coat on, kind of thing. All right. Break tasks down into simple steps, giving one direction at a time. Again, we're back to, if you give go in the other room and get this, and I need this, and it's the green one on the left-hand side, that's not going to happen. Okay, so just short directions. And ask one question at a time and wait for an answer. We have a tendency to ask a question, and then if the person doesn't answer right away, we're asking the next question, or we're explaining the first question. We have one question at a time, all right? And if they're really struggling with that, then you might want to reword it into something that might be easier for them to understand, but still one at a time. This is also really important. And I think it's important to do this with children too. Talk in positive terms. So in other words, tell the person what you want them to do, not what you don't want them to do. Because if I say to them, don't go outside without a heavy jacket and mittens and a scarf today, it's really cold. Now I've put the responsibility on that person to say, okay, don't do that. So what am I supposed to do? Well, somebody who's in the mid to later stages of Alzheimer's is not going to be able to figure out what you want them to do. So tell them what you want them to do. Back to, we're going to go to the bank. Go get your jacket out of the closet. That's it. And then you can be quiet. You don't have to fill the space with words. Okay. Use names when you're referring to other people. So not him or her, well, she said, blah, 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 who said? Even if the person is in the room, because they're going to forget who that is. Well, Evelyn was saying, or Evelyn the nurse said. So you're just reminding the person of who all the players are. And this one is hard. You really need to treat the person with dignity and respect. That person is an adult. They're not a kid. I can't stand when I hear people say honey and dear. It just goes all over me. It always has. Now that I'm in my late 60s, I can look at a cashier and say, honey, really? I'm old enough probably to be your grandmother. What are you, in high school? Or what are you, still in diapers? I mean, come on. But it's really easy to fall into that because, as people are regressing, they are going back to more childhood types of behaviors. And so it's easy to sort of then act like, and how often have we heard families say there's a role reversal? I feel like now I'm the mother and that's true behaviorally, but the fact of the matter is that these are still older people, and so we still have to treat them that way. And then the other thing that I would say in terms of communication is to ignore harmless hallucinations and delusions, because confrontation can really make the situation worse. So if you're working with someone who absolutely insists, and I have a client in mind that we know has been, on Joyce's books, who absolutely insists on, somebody was in my house last night, or, whatever, just be reassuring. Okay, we can look into that. Or in your case, it's really easy for you to just say, you know what, I can report that to the program coordinator. And And if the person perseverates, which they have a tendency to do, they're going to keep coming back to that. Yep, I'm writing it down. I'll report that to Joyce, and she'll be in touch, because darn well after you leave, they're going to probably forget that anyway. All of these things, though, if you as volunteers begin to see things that are out of the ordinary in your clients, you are the boots on the ground. So those are the things you're going to want to let Joyce know about. Especially if it's something that is really uncharacteristic for somebody. Because the other thing you have to remember is dementia can be caused, there's short-term dementia. It can be caused by medications, either too many, too little, I just got put in a new one, there are drug interactions. It can be caused by diet. It can be caused by dehydration, a urinary tract infection. It can be caused by a lot of different things that are treatable. So my general red flag for that is if you're working with a client that, always looks like they stepped out of the Montgomery Ward catalog, and you're all old enough to remember Montgomery Ward, that's why I said it, and suddenly they come to the door and they're all disheveled and they're still in their pajamas and they just, they clearly haven't taken a shower or bath in a few days or whatever. Something is really amiss here, and that. So that you're going to want to let Joyce know, because that usually, if it's that sudden, it's not Alzheimer's disease. It's probably not that. It's something else that is hopefully treatable, that can be fixed. And I've had lots of experiences with that where, suddenly somebody didn't know who I was and, was just very confused, and that just wasn't the normal sort of pattern of behavior. So if you see, sort of a natural descent, that's one thing. If you see that over time and you're letting Joyce know that, but if it's very sudden, usually there's some other cause for that. Okay, and I want to finish with some do's and don'ts when you're working with people with Alzheimer's disease. So we're going to start with the positive. Do. So you want to really keep everything as simple as possible. What you're telling them, your instructions, just all of that. Try to keep that as simple as possible. Expect it. They're going to ask the same questions over and over and over again. So as long as you're prepared for that, give the person only simple tasks to perform. So it might be, drying the dishes. It might be, if you're emptying, the dishwasher, it might be just separating the utensils and putting those away. Just simple things that they can do. If possible, keep the person occupied with simple chores, because the worst thing for any of us is just kind of sit. So that's not a great option. Be gentle. Remain calm and pleasant as much as possible. A lot of these are reviews. Give instructions one at a time. Try to ignore the things that the person does that can be annoying. And let's be honest, we're all human beings, and these people can't, whether they're family, whether they're clients, whether they're neighbors or friends, some of this stuff can be so annoying. It's just like, oh, if she asks me one more time, did we eat dinner, or what are we having for dinner? I'm going to scream. Just, try to ignore that. Hold the person's hand. If it's somebody who likes to be touched, touch them. Hold their hand or put your hand on their arm. If they like to be hugged, especially if it's family, do that. And I think this is one of the most important things, and that is to maintain your sense of humor. My mother told this story one time. I went down to visit, and I was going down, as I said, about every 6 weeks. So my mother had restless leg syndrome, and she used to get, a lot of pain in her legs periodically. So she and my dad are watching television one afternoon, and she was in a lot of pain. And that was very disturbing to my father because, again, remember the feeling thing. And he was pretty nonverbal at that point, and he's kind of patting her. And my mother had a very high tolerance she had a high pain threshold, but she was really having problems. So she's telling me this story the following week. She goes, so the next thing I know, Dad gets up and he leaves the room. Now, my father didn't tend to wander outside. He would wander around. They lived in a townhouse, so he wasn't really going to go very far. So she wasn't worried, and he was still, continent, so she thought maybe he had to use the bathroom. So she said, I heard him in the guest room, which was in the front of the townhouse, rumbling around in there, and he comes back and he's carrying 2 wire hangers. And he sits down next to he gives them to my mother, and he sits down like, okay, now you're fine. You know, I mean, he didn't say that, but he kind of patted her like, this is what you needed. And my mother is looking at these 2 hangers like, what are these? Like, why did you give me those? But for whatever reason, that was the solution to my mother's leg problems by my dad. And he was so proud of himself because he thought, okay, so now let's just watch this show, okay? Because you're good. And, you know, my mother said, there I was in so much pain. She goes, I just cracked up. I mean, what are you going to do? She said, I just started laughing when I realized how absurd this was. And I think, you know, especially if you tend to use humor, which my family does, it can be really helpful. It can just really be helpful to be able to say, you know, in any other situation, this would be absurd and ridiculous. But I'm dealing with, this is not it. It's not any other situation. And we're dealing with somebody with, you know, with a progressive dementia. And so here we are. All right. So now those are your do's. Here are your do nots. Don't expect the answers to your questions to be accurate. You know, I mean, families do that all the time. Oh, did you see, you know, did Susan come and visit yesterday? Oh, no, I haven't seen, no, I haven't seen Susan. And I've had families keep guest logs so people would sign in, just so, you know, so when I was doing social work, and I'd say, oh, so Susan came yesterday to visit. Oh, no, she didn't. Oh, yeah, it's right in the book. Look. Oh, she did? Yeah, and I bet you had a wonderful visit. Oh, yes. And then, you know, we'll go into what we think might have happened when she visited. So don't expect your answers to be accurate. Don't, again, try not to get irritated when the person asks the same thing over and over. Don't expect to give instructions and have them be carried out. Now, that even includes if you call and you're working with somebody with dementia and you say, you know, I'm on my way or I'll be there at 10 o'clock. Don't be surprised if you show up and they say, oh, what are you doing here? Hi. Because that could happen, you know. Don't give the person too much responsibility. Don't argue with the person or scold the person. It's really more the arguing because you're never going to win. And all you're going to do is make things a whole lot worse. You're going to escalate the situation. They're going to get upset. Then you're going to get upset. Then they're going to get more upset because go back to they're basing how they feel on how you feel. Now they know that you're upset. So when you raise your voice and you get upset, that becomes really problematic for people. So I'll give you I have a great story that I used to share when I was teaching. I had, when I was working at Heritage Hall, I had a gentleman come in, and he was admitting his wife for a long-term placement. She had Alzheimer's, and she was in the later stages. And he said, so I'm doing all the paperwork and the intake and everything. And he said to me, if you have any questions, she was nonverbal. He said, if you have any questions about her or her care, call me. I don't care what time of the day or night it is. And and so I'm being, a little good social worker going, oh yes, of course we'll do that. He goes, no. He goes, look at me. He said, I am telling you to call me. You, the nurse, the doctor, anybody. So I said, okay. I said, you seem really, like he was really fixated on this. And he said, well, let me share a story with you. He had a caregiver coming into the home, a home health aide. And he was, at that time, working out of the home. This was way before the pandemic. This was, 25 years ago, 30 years ago. And so he said to the home health aide when she got there, let's call her Joan. Joan has a doctor's appointment today at 10 o'clock. I'm down the hall. He had an office, an at-home office. He said, I'm down the hall. He said, I have some phone calls that I have to make, some things that I have to get done before that. So please just make sure that she's ready at 9:30 so that I, can take her to the appointment. Okay, fine. So the home health aide gets her dressed and so forth. Now it's almost 9:30, and she says to Joan, okay, Joan, we have to put your sweater on. It's cold out. You've got a doctor's appointment. Well, that's when Joan decided, I know Mike won't let me move in this chair, but no, she's not putting the sweater on. And the home health aide said, okay, just, uncross your arms and let me have your arm. Now she started to take the arm. Well, you started to take the arm. Joan was even more, I'm not moving. Don't touch my arms. Get away from me. She wasn't saying that, but those were her reactions. Now the home health aide, who was very sweet, this is the husband telling me this, very sweet. Now she started to panic because what did the husband say? Have her ready at 9:30. So now what does the home health aide do? She's looking at the clock. It's like 28 after 9. She's not ready. She still has to get her shoes on and her sweater. So she managed to get the shoes on. Well, the sweater wasn't happening. So now we get into this tug of war because now she's escalating. The home health aide is escalating. Oh, please, Joan, come on, just let me just let me get your sweater on, blah, blah, blah. And of course, the more she's escalating, the more Joan is getting upset. So now we've got this situation that's starting to explode over a sweater. The husband now comes down the hall because now it's 9:30. So he's got to take her to the doctor's appointment. And Joan is nowhere ready to, and she's still had to walk out to the car. So he tells me the story. He said, so I go to the door, and now this home health aide is completely out of control. Like she's at the, almost screeching, please, please, she's begging with her, please put the sweater on. So the husband says, okay, stop. Go stand in the hallway. He said, it's okay. And she's, apologizing. I'm sorry, she's not ready. He said, no, it's okay. It's okay. Go stand in the hallway. So he goes over to his wife and he starts humming the song that they danced to at their wedding. And he's just humming like this. And he takes her hand. He's facing her. She's sitting down. He's standing. And he takes her hands and he's humming. And he goes, isn't this nice? Isn't this lovely? And she starts to calm down. And they do this. And he says to her, oh, come and dance with me. And she gets up out of the chair because she was able to ambulate, gets up out of the chair, and he's dancing with her. And he reaches over to the nurse's aide, or the home health aide who has the sweater, and he takes the sweater and he dances her out to the car. And while he's doing that, he's putting the sweater on and she's just doing whatever he wants her to do, and they dance out to the car. Okay, but that is the difference between letting a situation escalate and just figuring out creatively, how do we just keep this calm? And I think that was the message that he was giving me. I'm so glad that man told that story, because I can tell you, I taught at Springfield College for 12 years, and I told that story every semester, because I just think it's, first of all, families really know their people way better than we do. I mean, even though we've worked with them, and for some of you, I mean, Leah's been a volunteer for many years, you know your clients. But in a lot of cases, families have been with them for years and years and really know them. So those are the kind of ways you have to sometimes sort of think outside of the box. And then my last thing on your don't, and this is something that you almost never hear from a social worker, because most social workers, we are taught 1,000 times in school, people, give people their options, give people choices. But when it comes to somebody with Alzheimer's, don't give them a choice, because choices for them become really confusing, and that is anxiety producing. So if you hold two dresses up and you say, Joan, do you want to wear the blue dress or the red dress today? She's going to be, it's pressure. It's for them, it's pressure. So instead, you take out the red dress and you say, Joan, let's put you in the red dress today. You're so beautiful. It really highlights your hair. We're getting the red dress on, okay? And if she really doesn't want to wear the red dress, she's going to communicate that to you somehow. Then you take out a different one. But don't give them choices. Don't give them choices on, what would you like for lunch, this or this? You might say, we're going to have this for lunch. If they really seem like they don't want that, okay, then you can say, oh, well, okay, maybe instead of that, we'll have this. Let's go with that.